Good morning. My name is Lorraine Jacobs. Mark Miller and I are the co-chairs of the Sunday Morning Forums, and we welcome you and thank you for supporting the Sunday Morning Forums. For over 50 years at First Unitarian Society Milwaukee, the Sunday Forum Lecture Series has showcased speakers. Forums are 1 hour in length and provide a presentation followed by questions. Scheduling and hosting these weekly programs is accomplished by volunteers. The presenters do not receive honoraria. The content of each forum may not always align with the viewpoint of First Unitarian Society in Milwaukee. They are meant to offer topics which can be pursued further independently. Before we begin today, I'd like to remind you that next Sunday, April 17th at 10:10 a.m., we will have an in-person in Max Auto Hall forum with the Zoom support. And it will be How Can We Stop Gun Violence with Deha Garner, a Director of Equity and Outreach with the Wisconsin Anti-Violence Effort. And today, we welcome Suzie Ryer and Dr. Ed Duthie, and they will be introduced by today's forum host, BJ Ermick.
Hi, everyone. It's wonderful. It's wonderful to be here with you in person, more or less. My name, as Lorraine said, is BJ Ermantz, and I am both a member of the First Unitarian Church as well as the Milwaukee County Falls Prevention Coalition. The coalition was established in 2019 and already has accomplished amazing things. They are an interprofessional group of community members, health systems, government agencies that all aim to increase collaboration and establish a framework to promote fall screening and prevention in Milwaukee County. Suzie Ryer is a senior project coordinator in senior services at Advocate Aurora Health. She is the co-leader of the group, and she is also a physical therapist who is board certified in geriatrics. With over 15 years of experience in various clinical settings. She is not only active locally, regionally, but also nationally, especially in geriatric emergency department quality throughout the health system. Dr. Duthie is one of the steering committee members, and he has received his Doctor of Medicine from Georgetown and a fellowship in geriatric medicine at the Jewish Institute for Geriatric Care. We have been fortunate to have him at the Medical College of Wisconsin since 1985. He has been the division chief of the Medical College Division of Geriatrics Gerontology. This field requires interdisciplinary teams to address the bio, psycho, and social needs these patients often have. It's a system of care that goes beyond the medical to help patients and families cope with the multiple complex illnesses and problems. And I'm not sure which of you will be talking first, but I will now turn it over to you. Thank you so much for being here.
Thanks, BJ. I think I'm going to lead us off, and Susie's going to handle the slides. Have you put the first slide on, Suzie? I'm going to share our screen here.
Oh. Helps if I share the screen, doesn't it?
Perfect. So hopefully everybody can see the screen. I cannot see the chat with this view. So Suzie, if you can monitor that, or BJ, much appreciated. So we're going to take you on a whirlwind of falls. We have a limited amount of time this morning. I can tell you there are complete courses on this topic, so it's very hard to know what to squeeze down. I have three things I want to accomplish this morning. Suzie will speak to you about hers. And the first thing I want to do is I'm going to scare you with some very sobering and scary data. The second thing I'm going to do is I want you to understand today is that falls are preventable. And the third thing I want to do is tell you what you can do as a healthcare consumer to prevent the problems. First thing to speak to is the scariness of this situation. So every second, an older person falls every day in the United States. And this is a very busy slide. It shows a lot of information, but what I want to show you is these little pyramids that are on either side that show in 2018, 36 million falls occurred among the older population in America. And in 2030, it's projected to be 52 million. And the little spot on the corner there shows that injuries are only the tip of the iceberg. So the first message this morning is that when we think about falls, we shouldn't just be thinking about injury, okay? Now, what's very sobering and very worrisome to us in the geriatric community is this graph on the right that shows death rates per 100,000. So the first pyramids you saw on the left show that the geriatric population is growing and the number of falls get larger because there's an older geriatric population. But when we control for the number of older people, which is done in this second graph, we see this alarming increase in mortality associated with falls around the United States. And this is in spite of a lot of efforts by people like Suzie and myself to try to bring awareness and fix this. So we know that in the younger population, in your children and grandchildren, unintentional injury is a leading cause of death, motor vehicle crashes specifically. But in the geriatric population, we can't forget about unintentional injury as a cause of death, as shown in this slide here. And it's not getting better, and we have to do something in this country to try to prevent this problem. Next slide, please. So this is the litany of problems that older people experience when they fall. This is absolutely positively not the way a fall should present to a doctor. The horse is out of the barn when we have fractures and soft tissue injuries and people laying after a fall for hours and hours and even days and suffering with that. Emergency room visits, going to nursing home, all of that is way too late. So we'll talk about how we would like falls to present in the practice of medicine. This is the equivalent of waiting for a stroke before you start treating your blood pressure. And all of you in the audience know that for decades, the United States has been advertising the fact that high cholesterol, high blood pressure sets you up for strokes. And I'm very happy to tell you that over the last decades, that your parents and grandparents suffered from stroke much more frequently than your generation does. So we've learned that by nipping something in the bud, we can prevent a lot of human suffering. But with falls, we haven't quite gotten there to the same degree. And that's what we're going to talk about today. Now, I'm sorry, Suzie, just one more point about that. I did want to say that on the bottom, when you look at these other entities, this is also how falls present. And everybody in this audience has had a thought about, do I really want to go out today and be with people and socialize because there's slick leaves, there's ice on the ground, etc. And so we see our geriatric colleagues and patients saying, boy, my social life, I'm beginning to feel lonely. I'm not interacting as much because I'm frightened about this occurring. And I've seen it in the younger population as well. So these are some other things that we don't think about so commonly, but that do occur. Next slide. Thank you, Suzie. So we do have something called STEADY, which you'll see down in the bottom there, and Suzie may talk about this some more. And they've had these brochures. This is one shown here. And they point out, these are programs by the Communicable Disease Center, the CDC, and others that help us to start and enlighten some of our thinking about the topic. And so they raise the question, did you have a fall in the past year? And this is the way we want falls to present at a medical visit, is your doctor and you having a conversation. And every elderly person once a year should have this question posed. I can't, at Freighter, I will fully disclose, we were not doing the best job on this. And so we had a movement put forward, a quality improvement measure, so that now every appointment for everybody, no matter where you go, dermatology, urology, wherever, they will ask you this question, so we do the proper job on it. And you might say, well, what if my dermatologist asked me and I tell them I did fall? What do they do with that information at your dermatology clinic? And the answer is they tell your primary care doctor. And I would really urge you to have these conversations at your Medicare wellness visit. That's the perfect place to be discussing your gait, your balance. So every geriatric patient once a year should have a conversation with their healthcare provider about falls. And we recognize that this is a long list of things you and your doctor are talking about: blood pressure and cholesterol, cancer screening, et cetera. But this needs to be factored in if we're going to make a dent in those fall numbers. And I do want you to start to think about this differently than an accident. We don't use that word in medicine. At the medical college, the injury people have told us, get rid of that term from your vocabulary. So we refer to this as unintentional injury, and we think about this as something that's preventable. Okay, next slide, please. So we need a definition, and this is a very simple definition, which is you end up on the ground or a lower surface. So going backwards on the couch counts, okay? I have patients tell me, oh, that isn't a fall. I didn't end up on the floor. We said a lower surface, okay? So, and purposely, you didn't intend to be there on that low. So it's not when you're doing, flipping jacks and one thing or another, but this is something that was unexpected, okay? And so it does include slips, trips. You know, I have so many patients say, well, that didn't count. I tripped. I could have tripped when I was when I was another age, and that's possibly true. But there is no question that with age, your balance changes. And so that the slip now, or the trip, rather than resulting in you losing your balance and catching yourself, now you end up in another place where you didn't want to be. What do we mean by does not include a medical event? What we mean is a fainting spell. So we do know older people are more likely to faint, and you don't want to confuse that with a fall. The doctor needs to know the difference because the causes are entirely different. So we're here to talk about falls today, but when you're talking about fainting, you're probably more in the cardiac area, and it's a much different animal than the patient who falls and stays conscious. Next slide, please. Well, we have risk factors for falls. And if I was to say that age is a risk factor, falls are a risk factor for the little kiddies. So this is something that you and your little great-grandchildren have in common. But you know, when that little kitty falls, they just bounce up like a little piece of rubber. While when you fall, or we fall, there can be other consequences with our bones cracking and the like, okay? We're not going to talk a lot about age because we can't fix that. We're old, and that's the way it is, right? And there's not much we can do about our gender, and there's not much we can do about our ethnic background. The things we can fix, though, are the shown on the left-hand side, and we'll go through some of these today. But again, the message this morning is falls are preventable. This is not just something that happens because you're older. We can do things about this. Next slide. Okay, so we're going to have a few simple topics, and then I'm going to turn things over to Suzie. Actually, I think I'm running over, so I better go fast. So we want you to speak up at your doctor's appointments. We want you to keep moving. We want some eye checks, and we want to make sure the environment is good. Next slide. So we already talked about this. Tell the doctor. It doesn't hurt to let the pharmacist know either, because when they're counseling you about the drugs, they can also make give you some insights. And then this Stay Independent brochure, which we'll hear about. And then again, be honest with your healthcare provider and let them know if you're fearful. They want to hear about that. Next slide. Keep moving. Exercise, exercise, exercise. And I'm not talking about running marathons. I'm talking about gait and balance. And every geriatric patient once a year should have their gait assessed by a healthcare professional. It could be Suzie as a physical therapist, it could be your doctor, nurse practitioner, but everybody should have their healthcare professional look at their gait and balance, which helps us to stratify your risk and then make specific prescriptions on your exercise to help with this. Okay, next slide. So the exercise recommendations are going to be tailored. If you've got terrible osteoarthritis in your knees and hips, there's going to be a different program compared to the person that's got what we call peripheral neuropathy, or other people that have brain lesions that might be affecting their balance. I can tell you, as a geriatric person myself, that the thing I've noticed most about my own personal aging is my balance. My balance is different. Your balance is different. And believe it or not, we can fix that. It can be made better, but you need to put your mind to it. And as we said, and the slide shows here, this isn't easy stuff. You got to stick with these measures because your body is changing over time. And if it's not just a one shot, I go to a balance class and then I'm good to go. You've got to be practicing these things. And I know some of you in the audience have done this. Next slide. Suzie, I'm kind of, there we go. Okay. So here's some local resources. Suzie will talk more about this, so I'm not going to belabor this, and she'll tell you where our website is. Next slide. Thank you, Suzie. Something's in the chat about the balance. Make your home safer. You know, for your grandchildren and great-grandchildren, that they kid-proof the house. And we would not leave a stairwell open for a 2-year-old toddler to go tumbling down. And folks, I don't mean to compare aging and young childhood, but the fact is that we take our homes and environments for granted, and we sometimes think that the home we moved into when we were 35 is the same place for us now that we're 85. And the answer is we have to look around, and some things that we used to love and cherish, our favorite Persian rug or something like that, is now a hazard, and the place needs to be modified. And there are these checklists available, and if need be, therapists can come in, particularly occupational therapy, but also physical therapy, and inspect the place and kind of let you know this is what needs to be done to make it safe for yourself. So we do have to be attentive to our environment. Next slide. This is somewhat a no-brainer, which is vision. Your environment becomes hazardous if you can't sense it. So we should be having regular eye checks. Many of you have had cataract surgery, I know. And those of you who wear bifocals, and I am one of those people, know what it's like to look down. And the first time you start with a bifocal, you need to be prepared that the world is going to look differently and caution is needed, okay? And there is some data about cataract surgery reducing the risk. It's not a panacea. I'm not going to say that, but it can play a role in helping you. So please have your vision checked. Can't overemphasize drug use. I don't know a drug that doesn't cause dizziness, okay? Some are more prevalent than others. There are drugs that are particularly dangerous. I can't overemphasize sleeping medication. I mean, there are just so many, and patients can get this over the Tylenol PM. You can get over the counter. You don't need a prescription for it. And these things can create problems at night for our older population. So please have these conversations with your physician at the time of falling. Am I taking something? Blood pressure medicine, heart medication, diuretics, these things are all notorious for creating problems. And the fewer drugs you're on, the better. Believe it or not, after you get over about 3 drugs, the fun really begins. So don't forget about medications. And then something that BJ has sensitized us to, and I think is absolutely true, is the issue of alcohol. And you all remember in your younger years, the young people joke about it, falling down drunk, this, that, and the other thing. And that doesn't go away as you get older, and may become even more problematic with the risk of drugs. So please, alcohol, drugs, things like that. Next slide. Sorry, Suzie. Well, and how could we forget a couple of other things? Another thing that BJ has sensitized us to is untreated hearing loss. And I know it's a strange connection, hearing and falls, but they are epidemiologically linked to one another. And that is something that can be fixed. So why not? I mean, this kind of simple idea here is that you get warnings in your environment. A kid on a skateboard is trouble if you're coming around a corner. And if your hearing isn't up to task, you might not hear it. Best case scenario, you turn the corner and you're startled. Worst case scenario, you get hit by the kid on the skateboard. So anything you can do, again, to be in touch with your environment, the better. And then for those of you who are runners and the like, and all of us as we get older, our feet start to change. And they arch flattens a little bit, and we start to notice calluses and things like that. And footwear is absolutely critical. And how many falls have I personally seen with people wearing shower sandals, broken down footwear, you know, their favorite things, they go out to get the paper in and they just slip their feet into them. And the next thing you know, we've got a problem. So if you really got some considerable foot problems, you may need to bring podiatry in to help you and get fitted for the proper shoes. And as the slide shows here, even in the house, folks. Next slide. And with that, I'm going to turn things over to Suzie.
Great, thanks so much, Dr. Duthie. As Dr. Duthie was talking, I did drop a couple things in the chat for you. The first that I'll just reemphasize is the CDC Study Toolkit. I'll talk about that a little bit more as I kind of walk you through what's available through our coalition website, and you can certainly access those tools there. But the CDC really took some of the best guidance from our national leaders and put those tools together in a way that are very easy to use. That Stay Independent brochure that Dr. Duthie mentioned about doing your own self-screening is really great. And so you can access those through the link that I included. As well as a link to, a lot of people are asking about exercise classes, and the Wisconsin Institute for Healthy Aging, which is one of our partners here in the state, helps to bring some of the best evidence-based programs for a wide variety of topics, but several really relate to falls. And I've included the link for how to search for those programs and where those are available. And I'll always put an extra plug in for, you know, strength and balance being really the hallmarks of a good exercise program if you really want to reduce falls. I always encourage people to keep walking because it's great from an aerobic standpoint, but when we start to talk about fall prevention and reduction, it's doing some strength training, it's doing some balance training, some flexibility training. And, you know, there's lots of great classes offered through the YMCA. Well, it was mentioned, there's a program called Enhanced Fitness. So searching through those local resources is a great starting point. So I'm going to shift gears a little bit from talking about how you can reduce falls to really telling you what we're offering in the community and what our efforts have been to try to bring together, you know, a coalition to really address this issue of falls from a more holistic standpoint. So the reason this is such a big issue here, particularly in Milwaukee County, is because we have the highest rates of falls in the nation. Wisconsin's actually triple the national average, and we've been the leaders for quite some time, particularly as it relates to fatal falls, deaths from falls, as Dr. Duthie talked about earlier. Here in Milwaukee County, we have amongst the highest fall-related emergency department visits, and we see many more people being affected by falls than some of the other things that we put a lot of prevention emphasis on, like breast cancer and prostate cancer. So really hits home why this is such an issue in our community locally. So that really led us to this idea of creating a County Falls Coalition. My mentor and physician leader at our health system, who's a colleague of Dr. Duthie, always likes to share these DOTS candies. And he was in a meeting with some of our EMS colleagues, and they took out this box of dots and said, you know, this issue of falls and all of our different organizations, we're like a box of dots. And he spread them out amongst the table and said, somebody needs to help us connect these dots, bring these together. And I think that's really what we've seen in this journey around falls prevention and bringing the community together, is that we're all doing a lot of great work in our own silos, but that there really is a need to come together and address this more as a community. Obviously, we have an aging population here in Milwaukee County, and there's a need to focus, like Dr. Duthie said, way before that first fall happens, but in that prevention realm. When we start to address things after the fall, we're really missing the opportunity to improve care and outcomes. And again, because falls are preventable, and so there's something we can do about it as a community. So as BJ mentioned when she introduced us, we started in 2019. We were doing a lot of work in our emergency departments around care of older adults. And of course, the first thing that we talked about in the emergency department is falls and how many of our older adults were presenting for falls. So this work really started with saying, how can we do a better job of working upstream of the emergency department and preventing falls in the first place? So this coalition came together with the idea that here in Milwaukee County, we want to be national leaders in the prevention of falls by better bringing awareness to the community, creating some collaboration between our community partners, and really being innovative in the things that we offer, particularly in the area of community education. When we met with community, we did a community needs assessment through focus groups, conversations with older adults in senior centers and various other parts of our community, and really 5 main themes came up. And I'll talk a little bit more about, how this translated to our strategies, but we really saw, the issues being the stigma around falls. It's really hard for people to talk about having falls because there's so much negative connotation associated with that it means loss of independence, having to leave your home, not being as independent as you used to be. And so, that really creates this problem that's kind of living in the shadows. And anytime that something's in the shadows, we're not doing a good job to prevent it. We saw a lot of lack of collaboration between our various entities. We have great programs for fall prevention in our hospitals. We have great resources, and we've got great things in our community, but neither one knows how to connect each other to those particularly well. And so trying to find a way to do that. We've also struggled with how to really get a handle on the various data points around falls. And I know this is a conversation Dr. Duthie and I have had many times, but unfortunately it takes a while to get some of that larger, more impactful data around mortality and fall injuries. And so really being able to track not only what the rates of falls are, but where in our communities is that happening? Are there particular pockets of our city that are most vulnerable that we can really help to better serve? There's a lot of national resources, as I've mentioned, but unfortunately, it's not always easy to access these or know what the right ones are to use in the right circumstances. So trying to create that. And then the issue of having these fall prevention programs, evidence-based classes and screenings available in the community. We know Milwaukee County is very diverse. We have big disparities between what's offered in our suburbs versus what's offered within the city itself, and especially in communities of color and non-English speaking communities. And so trying to get a better handle on where those programs and screenings are offered and how we can help to fill those gaps. So we've set out some strategies that really aim to address these key themes and these kind of areas of problems that we've seen as it relates to really improving and addressing this issue of falls. So a lot of our work that I'll start to describe in a few moments has focused on the idea of improving communication, having a broad strategy for allowing us to talk about falls within the community, establishing some dashboards within our coalition that help us to monitor different fall rates, fall trends, as well as the different ways in which people interact with interventions that we promote. Really trying to create these connections through our monthly coalition meetings to have organizations better connected to each other, to be able to have those smooth handoffs. Understanding what fall prevention programs are being offered and expanding those offerings here in our community. And then creating some toolkits. And I know BJ's got a few that she picked up from me yesterday, and I'll talk about those in a moment, but providing some comprehensive education and toolkits that really help to get those resources into people's hands to understand fall risk. A little bit about our structure. So we are a 13-member steering committee, of which Dr. Duthie and I are both members. And our steering committee was formed really to bring the various different kind of professional lenses to, setting our strategies, leading our action teams, and having this collaboration. So we have health system, community members, folks from public health, from the county aging services. So a really diverse representation. Our coalition's made up of about 40 members and organizations. We started meeting in person in 2019, September of 2019, when we kicked off our coalition. And then this little thing called COVID happened. And so we took a very brief pause and then switched to virtual meetings like many of you have. And our coalition is structured such that we can do work in subgroup action teams, as well as come together monthly to share community stories, talk about what we're seeing in our own organizations, and really create this framework of collaboration. We've got a lot of different organizations who are involved, and we're continually trying to expand our horizons and think about other individuals who can provide a different perspective. Recently, we've put a little emphasis on trying to increase our engagement with our university health profession programs, nursing, physical therapy, working a little bit more with our managed care and some of our payer sources, even getting the perspective of our long-term care facilities to help us to frame the work that we're doing, and home repair specialists, people who have that perspective on how we can make homes safer. So trying to really connect with as many folks as we possibly can. Our goal is really to try to make impact in the community, not only to reduce these rates of falls and to address those kind of large health outcomes, but also to help people to have the resources and tools and interaction with the things we're doing. So I'll kind of talk about some of the things we've done over the last couple of years, and then where we're hoping to go in the next little bit. So obviously, like many, we had a little pause for COVID and tried to really adapt the work that we were doing, which initially had been focused on a lot of community interactions. So we had put some resources out into the community, tried to create some one-pagers as a way to help people to just have a quick snapshot on a particular risk factor and try to address those. We also switched to virtual meetings, and we've become moderately competent at Zoom over the last year or two, I'd say. We work with our partners at Milwaukee County Aging Services, which used to be the Department on Aging, to put out a monthly social media post that then provides specific information on one area or topic related to falls as a way to kind of get people thinking about something each month and provide a couple things that people can do. Most recently, we talked about medications, obviously, and Dr. Duthie talked about what an issue that is. And so our goal with that is just to put information out into a diverse audience's lens. We have a website, which I'll drop the link here into the chat, but our website is really designed to be kind of an entry point here in the county to the various resources you may want to access. So we promote some of the fall prevention programs that are going on in the area. We've got some monthly tips of the month that are building upon those social media posts. We link to various other programs and services that are going on, as well as ways that you can connect with other individuals who may be doing work around fall prevention, and a lot of one-stop shop for some of those resources from the CDC study, things about exercise. And then we've got a print newsletter we put out twice a year. This is the toolkit, and I know, again, for those in the audience, BJ's got some available, and we can certainly arrange to have more available for you all. But these toolkits are designed to have the check for safety brochure, that self-screen, the stay independent, information about how you can increase your exercise, and then there's a nice magnet in some of them that talks about what you can do to keep your home safe. We've been working with some of our paramedic units. We've got 2 of our local paramedic units that have what's called mobile integrated health, where paramedics come out after a medical event, and they'll actually do some health counseling, and they'll do some additional resources. We've got some in Greenfield and as well as in West Dallas that we've been working with. And they've actually been taking these out after someone has had a fall and called EMS and been able to walk them through the materials and help them to do some self-assessment in terms of fall risk. We also have been working with some of our provider groups, including the EMS providers. Dr. Duthie and his action team did a really great education on fall risk to help our firefighters and EMS professionals be more in tune with what they see when they go out to respond to a call, and how they can connect folks who fall in with resources, particularly those who may not be going to the emergency department but are staying at home, and to make sure they have that follow-up care. This last year, we were lucky enough to be able to get out into the community, and we did some outdoor resource fairs. We had 2 different resources fairs during National Fall Prevention Week, which occurs in September. And so we were out at the Hart Park Senior Center, and then we were also at Clinton Rose, which is down on the near north side. and had a great opportunity to talk about fall screening with about 130 older adults who joined us at those two sites. We also had the county executive who you'll see doing exercises in the lower right-hand corner. So we've really been trying to work with the county to align our efforts with those of the county, particularly as it relates to diversity, equity, and inclusion. So some of the things that we're focusing on right now is to continue to grow our communication strategies. One thing that we found really helpful is sharing the power of stories in the work that we do. So each month at our coalition meeting, we feature a different community member who shares the personal impact of falls on their life or that of their families. So it may be a caregiver, it may be someone who's had a fall. And so we're working now on putting those together into a library so that we can continue to share those stories, because I think they're really meaningful, not only to keep us grounded in the work we do, but to help normalize the issue of falls and how people have grown from those experiences. We're continuing to grow our community outreach events, and we'll actually be going out to the United Community Center this spring to do a fall prevention outreach with our predominantly Hispanic speaking population. We're just finishing a resource list that will be available on our website, which will be a great one-stop shop for all the different exercise classes and fall prevention programs being offered throughout the county, as well as information about where they're located, how often they're located, to help people to be able to find those a little bit easier. And then just most recently, we have partnered with the ERA Senior Network that does the Faith in Action program, and are in the early conversations about creating some education and resources for their volunteers who can really provide that neighbor-to-neighbor perspective on fall prevention and help to kind of keep that conversation going. I talked a little bit about these things already, but again, our priorities really focus on that idea of increasing our reach, being able to expand into communities of color, and really improve those connections, particularly between our county aging resources and then those who really have the most opportunity to put those resources in individuals' hands, such as our EMS providers, volunteers, and others working in the community. We'd love to have you join us or to stay in touch with what we're doing. If you go out to our website, and I'll drop that here in the chat in just a moment, there is a place that says if you're interested in joining us or being on our mailing list, we do send out various updates, our newsletter, things like that. So you can certainly join us on our mailing list by either emailing this address or going to our website. And then certainly I'm always happy to answer any questions that folks may have, and you're welcome to email myself or my co-chair Ann Gallo, who I lead the coalition with. We're so grateful that you gave us some time to talk today, and we would welcome any questions that you may have for us.
Suzie, can I make a comment?
Yes, please, Dr. Duthie.
Yeah, so to the audience, BJ mentioned very kindly that there is no honorarium or payment for Suzie and myself to do this, but there is something you can do for us. And so our ask for all those who in the audience, live stream, wherever, is if you want to tell us your story, contact us. And we're asking that this is your story about falls and the sequelae, because what you can do personally by telling your story is you can influence the Milwaukee County Falls Prevention Coalition. You would meet with the steering committee, and you would turn this problem from being one of those numbers that I showed in my first slides to being a real person and sensitizing us and helping us to understand your problems and what we can do with the community. So the ask today would be, you have the numbers in the chat to contact us at, you send us a note, and we can do the rest in terms of setting it up so that you can share your story and help us in this situation. Thank you.
Yeah, that's a great point, Dr. Duthie. And I never cease to be amazed by how much I learn from the stories that I hear and from what people have done themselves. So that would be a great contribution.
Let's see. Can you hear me okay?
Yes.
Yep.
Okay, good. I have a question. You mentioned having an annual gait checkup. My question is whether there are specialists for that, whether we need to look for a PT or a physician who has special knowledge along these lines, or can pretty much any physician or any physical therapist do such an evaluation?
Great question. And the short answer is that I would start with my primary care provider and find out what their comfort level is in this regard. And some feel very comfortable and can do the first swack at it, so to speak. I would say a basic competency for any nurse practitioner, physician would be to do that first cut at the gait assessment. In medical practice, people that have special expertise in this would be physiatrists. That's a specialist in physical medicine and rehabilitation. Neurologists also have some special expertise, but the family physician and the internist can also be a great place, as well as a geriatrician. Physical therapists all can do this for you, but that might require, in terms of payment, I don't know, Suzie, you can comment on this, but sometimes a referral and a diagnosis is sometimes required on that. So, so as to get full advantage of the reimbursement, you might need that. But Suzie?
Yeah, and I will echo that with Dr. Duthie. Oftentimes, if you start with your primary care physician, especially at that annual wellness visit, any concerns about falls, there's some diagnoses that they can use that can be a good trigger for that more comprehensive gait assessment. And I think that's the piece where, if there is some concern from that primary care physician, that referral to the physical therapist for more detailed gait assessment is a really great opportunity. Much like the physicians, any physical therapist should be able to do some of those, initial kind of screening of gait and balance. But there are therapists who specialize in neurological disorders, in balance, in geriatrics. And so, when you have the opportunity to see one of those more specialized therapists, they'll be able to take a more comprehensive look at, all those various risk factors that may contribute to falls, particularly if falls or multiple falls is a concern. But starting with the physician is usually a good point, just because of the reimbursement with Medicare and some of our other providers. Some of our therapy clinics will offer a free screening, or there may be an opportunity to come in, and that's another opportunity where you can start, and then they'll make a connection back to the physician as well.
And then in terms of the hearing test that you suggested, that is an area of specialization, right? An audiologist or something like that. And
yeah, usually there can be some very basic screens that are done in the office where, the one trick I learned as a geriatrics fellow was you get behind the patient and give them some instruction. And if they do nothing, you got a problem. But there are some other things that can be done to just kind of do some fundamental screening. We use something in our geriatric clinic called the audioscope, which is a little device that is nowhere near what an audiologist can offer, but it gives us an idea if a person has a problem. But yes, you're correct. An audiologist would be able to give us a better sense and do the fine tuning on things.
Yeah. Do you suggest we wait until we think we're having some hearing problems, or is that something that we just ought to?
Well, again, as Suzie said,
at a certain age?
yeah. Usually the insight can be faulty, as any spouse knows. So what we usually do is recommend that at the Medicare wellness evaluation that particularly if somebody comes along, this isn't a bad idea, that they can highlight that. Probably I would not wait for the self-insight, because that often we delude ourselves.
I see we've got a hand raised from Dennis on the Zoom. Dennis, did you have a question?
Yes, it seems like most everything you've been talking about falls within the home. But here in Wisconsin, we have a lot of ice in winter. And for about 12 years, I used to take the city bus from UWM down to the Badger bus station. And two things. One is the number of sidewalks that were never cleared. So is there some way that the city can be more attentive to that? And the other was, riding that bus was like being on a Bronco sometimes. And I was often fearful just to get to the door to get off. So if I didn't exercise as much as I did and my balance were poor, I'd be pretty intimidated by even riding a bus here in Milwaukee.
Yeah,
Great
that's it.
suggestion, Dennis. I think what you're saying to us is how we included in our Falls Coalition some of the outdoor environmental people that our taxpayers have some control over, and I'm not sure we've done as good a job as we should. So I think that's a great idea for us and a connection we need to make.
Yeah, I would echo that. And I think, again, as we strive and as we've had recent conversations with our county partners, as there is this strive to really make our community a healthy community holistically, not just in terms of medical health, but, social health and our access to things, that's a really important piece. And being mindful of how people of all ages access the community, I think is a great point. I will stress from a personal level that, really explaining to your physician and especially a physical therapist, if you're seeing someone for balance, what people do to in their daily life, really helps to tailor that balance program. I know as a therapist, my balance training for someone who rides the city bus is going to look a heck of a lot different than somebody who's, driving in a car or who's not leaving their home a lot. So I think again, there's we have to understand that older adults, the population really accesses the community in a lot of different ways and be sensitive to that.
Dennis, Suzie and I have a colleague in Chicago who's been researching this, and there are very important insights that you've just brought up in terms of planned communities. So some of the higher end planned senior communities have looked at this specifically to allow for safe spaces to walk, et cetera. And you bring up another point in terms of trying to have safe neighborhoods. So those of us who are older can get out and not fear for our lives. I know you have the shooting program coming up next week, and that dovetails very nicely into that, because if Suzie teaches me how to do some good exercise and I want to maintain it, but I can't get outside my door to do it, we've got limitations. So this does get to be a wide network that you're indicating in terms of quality of life and things that we want to do when we start to talk about falls.
I would like to interject here that I am in Wauwatosa. We have a city commission for persons with disabilities, and we expand that out. We work a lot with the Wauwatosa Senior Commission. And one of the big things we've been talking about is what we can do to improve the city's services regarding clearing the sidewalks, especially when there's somewhat of a partnership involved. For example, along North Avenue, we have a lot of restaurants. Well, the street is plowed, but then the sidewalks are not plowed, or you can't get from your car, parking your car to the sidewalk. In addition to reaching out to your alderman or councilman or whoever in your community, that would be the first course. But we in Wauwatosa, we would like you to contact the Senior Commission or the Disabilities Commission, because we are getting much more active about advocating on behalf of all of these types of things.
Good point.
I see a question in the chat from Steve, was asking about insurance eligibility for OT visits in the home. Oftentimes, if there's a risk for falls, even if it's predominantly age related, as you have those conversations with the physician about, any particular areas of concerns, if there's been a history of falls, oftentimes that can lead to additional diagnoses that would help to support coverage for those OT visits. There are some partner organizations, some home-based, what they call outpatient in the home. So therapy clinics that will come and do your therapy visits in the home as kind of an outpatient. And many of those will offer a free home assessment or a screening where they can identify some potential areas and then work with the physician to, get that plan of care built and things like that. So there are some resources for that, and I'll see if I can drop a link in the chat for that.
Yeah, Steve, you're absolutely right. And I mean, we have to be realistic about this. We cannot have an occupational therapist going into every senior home in Milwaukee County or in Wisconsin. That's beyond the pale. So we do have, you hit the nail on the head. You said the person who is at risk. And so that's what the team will start to look at. What are those risk factors? And their algorithms, usually, one fall isn't going to do it. But if I do a gait examination and I've got a Parkinson's patient who hasn't fallen, but they're at high risk, I think we can then begin to build the case for the insurers to say that this isn't just, any particular case. This is somebody who's got a special need. Great question.
The other thing I'll put a plug for too is, many people are managed by a Medicare Advantage plan, or an insurance company. I don't know how many people in the audience have had a nurse case manager or someone from your insurance company call and talk to you about various things, whether it's having screenings done or offering you resources. And so there's more being available through those folks as well, in terms of fall screenings or links to some of those additional resources. So take full advantage of whatever your insurance or your payer plan is. And when that person calls to check on you, don't be afraid to ask, what's available to me in terms of fall screening? Can I have a home assessment? Is there anything else that's provided to me in terms of getting equipment I would need in my home? Because those are often things that are not put in bright, shiny letters on the insurance plan when you sign up for them, but they're available. And so it's worth asking.
Yeah, folks, everybody's going to be on the same page there. The insurer, particularly the Medicare Advantage, they're thinking about the cost of taking care of a hip fracture, the hospitalization, the rehab, and they know if they can prevent that, it's worth a pound of cure. So Susie's right. They have a vested interest in helping you in this regard, and you may be able to capitalize on that.
Well, that is a great idea. I do want to be cognizant of the fact that Suzie has to leave at 11. So as soon as you need to sign up, I just want to say thank you ever so much for providing the packets that I've distributed in person, and for speaking. We can stay as long as there are questions. One other thing I wanted to mention is that, again, in Wauwatosa, there have been COVID funds distributed, and the Joint Housing Coalition has been successful in getting money put aside for rehabs. And we specifically defined it for seniors who want to stay in their homes, but know that they are not exactly senior friendly. And they need to have maybe grab bars installed or just whatever. So there's going to be more information about that. But you may also want to reach out to the ADRC, the Aging Disability Resource Association here in the county, because as Dr. Duthie said, people are realizing prevention is a lot cheaper than treating what happens if you don't prevent it. And let's see.
Hey, Suzie, thank you so much.
All right, I'm going to head off, everyone.
Great
Thank you
job.
for having us.
You're welcome. There is, Dr. Duthie, just in case, there is one more question
Sure.
from Lorraine about living in a 55-year and over apartment building, which there's, a lot of those around. And is there a way to schedule regular balance workshops for those interested or who need this? And how would we find a qualified balance falls reduction exercise instructor? Whoa.
Yeah, and the simple answer to that is contact Suzie. So I think if you just use that contact information, we can see about that. Yes, there are, I think the magic words that you said here, qualified balance falls reduction. So this just isn't standing at your chair and doing a few things. There's science to this. There have been, we know it works when it's done properly, but you do want to be engaged with a group that can do it. And this is what this whole coalition is about. There are community programs that we can try to link you up with to see what can be done. But I don't have the answer for you right now. It would seem that we could make that possible. I know at Freighter, we offer the program Stepping On, it's called, which is, it's not just a one-time thing. It's a few weeks that it's like the old adage, you get out of something what you put into it. And so this program is not for the faint of heart. You have to be committed. You have to go regularly. And then there's practice, of course, at home. So I'd be leery of anybody who could say, we'll give you, a half an hour and you're good to go. You're going to need to invest a little bit of time in this, but it pays off.
Oh, and on that point, I just remembered that the county ADRC is sponsoring for free a senior leader training in May. I believe it's around May 10th. It's a 2.5 days. And that I would think it would be terrific if senior buildings would have at least one, if not a couple of people attend that, as to become the kind of in-person volunteer. And all it is to be a resource. You're not responsible for certifying anybody or anything, but it would be, I think, for someone who wants to be active and help others. It's right where they live. So, and the training, as I said, is free. I know I plan to attend it. So something to think about.
Thank you.
You're welcome. I think we have all of the questions answered. Is that correct? Okay. Dr. Duthie, this was fabulous. I am so grateful. And just to let you know, we not only have the people who are in attendance, which that number always varies, but because it is available on YouTube, we have a number of people who will tune in when they can. And right now there's no expiration date on these. So we know this information is going to pretty much stay the same until we can reduce those numbers.
Great. So reminder, if you have a story to tell and you want to share it with us, please reach out to the links that Suzie put in the chat, and we'd love to hear your story. So everybody have a great spring day. It looks like we've got a little sun and
Yes.
can get outdoors.
And it's supposed to get up into the 50s. Dr. Duthie, thank you so
Thank
much
you.
for all you do. I look
you.
forward to talking to you later.
Right,
Okay,
bye-bye.
bye. Wait. Bye. Wait. Oh, you stopped.